Assalamu alaikum, everyone, and a very good morning to all of you. I would like to welcome you all to the second day of our annual Shaukat Khanum Symposium. I would like to introduce myself. I am Dr. Azmat, the consultant endocrinologist at Shaukat Khanum Hospital. I'll be chairing this session, and with me, Dr. Waqas Shafiq, consultant endocrinologist at Shaukat Khanum, will be our co-chair. Specifically, we're going to be starting the endocrine oncology session right now, and we've got an exciting lineup of speakers. This time round, what we've done different is that we've included talk on pediatric endocrinology as well. So I think we'll be covering a wider variety of topics. And so without further ado, I would like to introduce our first speaker, who is Professor Ali Imran, who is an FRCP from Edinburgh and is a professor of medicine at Dalhousie University, Halifax, Canada. And he will be talking about a very important topic that we normally encounter in our cancer practice, and that is hyponatremia in cancer patients.
Hello, everyone. It's an interesting experience for me to record this meeting. I've never done it before, so forgive me if something doesn't go according to the plan. I was given the opportunity to discuss the diagnosis and management of hyponatremia in cancer. And that's what I'm going to try to do within the next 20-25 minutes. I do not have any relevant disclosures. During this talk, I'm going to talk to you about the important aspects of hyponatremia, what it is, how common it is, why does it happen, how do you determine how bad it is, if you like, and then how to treat, and more importantly, how not to treat. So first of all, how common is hyponatremia? It is defined essentially as a sodium level of less than 135 millimole per liter. And if you were to look at all hospitalized patients who come for various reasons, it occurs in approximately 20 to 30%, up to 30% of all hospitalized patients. In cancers, the prevalence of hyponatremia is somewhat higher, particularly in certain types of cancers, specifically lung cancers of certain types. The prevalence is much higher and can be as much as 50%. When you look at severe hyponatremia, which we will talk about in a minute, and that's typically defined as a sodium level of less than 130 or even lower than that, that prevalence is lower, and that's approximately 15% of your cancer patients will have severe hyponatremia. I'm sorry, this is jumping. Now, why does hyponatremia matter? Well, two things. A, it is a prognostic indicator for bad outcomes in cancer patients. And B, could it be a direct or independent cause of excess morbidity and mortality? And I think there are some soft data to suggest these two. In terms of the prognostic indicator, multiple studies have shown that hyponatremia is a marker for poor outcome in various cancers. And those patients who have hyponatremia will tend to have a shorter survival. That shows in both univariate and multivariate factor analysis. However, this correlation between hyponatremia and bad prognosis, that tends to hold true in those patients who have extensive cancer disease, whereas those with relatively limited cancer, it doesn't tend to be quite as much of a prognostic indicator. This slide essentially shows the association between hyponatremia and poor outcome, and essentially it's a survival curve, which is telling you that if your sodium level is lower, in this case less than 125, you have much poorer survival as compared to sodium level of up to 135, or in patients where sodium level is actually in the normal range. So clearly showing that, again, the point that I was trying to make earlier, that hyponatremia is a prognostic indicator. Now, it is also important to keep in mind that in patients who do not have a diagnosed cancer, if you look at those patients, then and those individuals who come with hyponatremia, and if you were to follow them, they have a high risk of developing cancer down the road. So they have occult cancer. So in this particular slide, for instance, those patients who came with hyponatremia without diagnosis of cancer, when they were followed over a period of time, they were more likely to have certain types of cancers, and more importantly, brain cancers and liver cancer. So, and hyponatremia, NYD, you should always consider the possibility of occult cancer. With regard to hyponatremia being an independent cause of morbidity and mortality, data are limited and somewhat less convincing. So in one meta-analysis, which did not specifically look at cancer patients, but all patients with hyponatremia, in those patients where sodium was corrected, there was an improvement in mortality. In another study looking at 57 patients, very small study, again, retrospective study, a lot of obviously other issues that come with small retrospective studies. Patients where hyponatremia was corrected, the survival was much longer as compared to those where hyponatremia was uncorrected. How do we grade hyponatremia? So it's arbitrarily graded into various categories, either mild, moderate, and severe, based on sodium level, which is 130 to 134 in mild, up 120 to 129 moderate, and less than 120 severe. Or it can be divided on the basis of acute versus chronic, which would be less than 48 hours, it would be acute. Or more importantly, as asymptomatic versus mildly symptomatic and severely symptomatic. And I think that's probably a much better classification when it comes to your treatment. So depending upon the symptoms, which I have illustrated, meaning mildly symptomatic would be a bit of nausea, perhaps dizziness, weakness, some confusion, and severely symptomatic, essentially going from confusion all the way to cardiorespiratory distress, coma, and death. How is sodium level controlled? Well, sodium is primarily, keep in mind, sodium disorders are primarily disorders of water concentration. It is very unusual. It does happen, but unless you have a patient who is severely dehydrated, loss of sodium due to vomiting, diarrhea, or severe loss of a severe reduction in the intake of sodium, for the most part, the problem of sodium is due to problem of water concentration. And the way your body actually keeps your sodium and water in a balance is through these hypothalamic osmoreceptors. These receptors are sensitive to the cell stretch, and if the cell is stretched, less stretched or shriveled, then that is going to be sensed by these receptors and will lead to increase in your thirst and vasopressin release. And as a result, your body will start conserving water and you will start drinking more. When it comes to causes of hyponatremia and cancer, by far the largest cause is SIADH. Almost 75% of your patients with hyponatremia in cancer, they have SIADH. And then less frequently, you're looking at other possibilities. This will be cancer therapy, medications, and there are a number, and I'm sure you guys know better than me, pain medications. And then in the end, there is this relatively small group of causes. These include diarrhea, vomiting, adrenal mets. These are incredibly uncommon, but by far the commonest of these is SIADH. In terms of symptoms, most symptoms are due to the effect of hyponatremia on brain and the adaptive mechanism which brain typically follows. So essentially, if you look at this top left-hand corner, when your sodium level is in equilibrium within the brain cells and also in the outside fluids, then your brain has a certain degree of water concentration. As soon as you get hyponatremia, it's an acute hyponatremia, your water will rush into the brain and this will lead to brain swelling. And that is when you will begin to have symptoms such as headache, nausea, and if it continues, that can lead to seizure and respiratory distress, coma, and death. However, if sodium level slowly increases, then the brain actually, through a mechanism that's not fully understood, there is a way in which brain actually offloads that extra water, and then it kind of retains or brings that balance of water back towards normal, and that swelling gradually gets better. So people are, most patients therefore who have chronic hyponatremia are relatively less symptomatic and are less in danger as opposed to patients who have acute hyponatremia. How do you treat hyponatremia? So really, before you treat, the key things that you really need to have as soon as you have a patient of hyponatremia is to, number one, you assess the severity. What's the sodium level? Is the patient symptomatic? And how quickly has hyponatremia occurred? And at the same time, you have to draw some basic tests. These include glucose, that's what I do, glucose, lipids, liver tests, thyroid function tests, cortisol, plasma and urine osmolality, and urine lights. And you have to rule out pseudohyponatremia. It's uncommon, but it does happen. So the reason why pseudohyponatremia occurs is actually shown here. Basically, if you have some other solid substance or solute in the blood, and that would be, it could be, lipids or something else. What that basically does is, when you basically check your sodium level and you put into an automated analyzer, it takes a small amount of blood and then it dilutes it. So when you have a lot of non-aqueous part within this tube, which is shown here by this red arrow, then you have less of your aqueous portion, and your sodium is actually within that aqueous portion. And when it gets diluted to a certain percent, this is generally 10 times the dilution, then what happens is that if you have less aqueous portion to start with, and you dilute it 10 times with the same amount of fluid, your sodium will be diluted more. Whereas on the in the left top, where you have a normal aqueous portion, and if that is diluted, the total amount of dilution obviously is less, and therefore your sodium level will remain normal. So this is actually a dilutional effect. However, if you are considering this possibility, then you can check your sodium level on the blood gas analyzer, because in that you don't really get dilution, so you can avoid this problem. But keep in mind, if you have anything like dyslipidemia or severe hyperglycemia in some cases, you can get pseudohyponatremia. So when I have done the basic assessment, which I mentioned earlier, from there onwards, I go into the mode whether I need to treat the patient first or investigate the patient first. So in my approach, treat first would be those patients who have a sodium level of less than 120. This is acute, particularly if it's an acute situation. If the patient is symptomatic, in that case, I will go with treatment first, and I will start the investigation, but I don't wait for the result of investigations to come back to me. I'll straight away start treatment. How do you treat? Well, the goal here is to make sure that you raise sodium level slowly. By slowly, I mean no more than 6 millimole per liter in the first 6 hours, and preferably 8 to 10 millimole over the 24-hour period. So the way we do in our center is, if somebody is symptomatic, we will immediately start them with 150 ml of 3% hypotonic saline IV in 15 minutes. You check sodium very quickly within an hour or so to see if sodium level is rising, and you can repeat it. So you can repeat your hypotonic saline, and it can be repeated every half an hour depending upon your sodium response. And as soon as your sodium level begins to rise, it doesn't have to rise too much. You quickly, if you raise it by about 4 to 5 millimole per liter, most of the time these patients begin to improve, and that will tell you that this is hyponatremia. You can repeat hypotonic saline if necessary more than twice as well. As soon as the patient has increased the sodium level by 4 to 5 or 4 to 6 millimole per liter and their symptoms begin to improve, we stop hypotonic saline, we put the patient on normal saline and give on a very slow infusion just to keep the IV line open, and then we check sodium frequently, and then based on that we adjust to keep the correction rate to less than 10 millimole per liter over 24 hours. And then, the correction from there onward should be very, very slow. What if you, by mistake, overcorrect? If that happens, then immediately, if the sodium level is rising too rapidly, stop active treatment. Consider giving electrolyte-free solution, and this would be like a glucose dextrose solution, and you can give 10 mils per kg. And you can also give 1 to 2 micrograms of DDAVP, and what that does is basically restrict your free water loss, and your sodium drop will slow down. If on the other hand you don't have any of those treat first symptoms, then all the rest of the patients, at least from my perspective, I would like to investigate them first before I initiate treatment. Now, how to investigate? If the patient is on diuretic, that may, particularly thiazide, that will confuse the picture, so you stop that. Step number 1, assess volume status if possible. And I say if possible because the main problem with the volume status is that even in expert centers, or where people who deal with hyponatremia on a regular basis, assessing volume status is not something that is very easy. A lot of factors are involved. Patient may be on IV fluids, or patient may have some other problem going on. So you have to be very careful. So volume status, number 1. Number 2, check plasma and urine osmolality and urine sodium. So these are the things that you need to do right away. If your urine osmolality is less than 100 milliosmol per kg, this means your kidney is producing maximally dilute urine. In that case, the likely possibility is primary polydipsia, which can happen in some patients with cancer, but it generally is very, very uncommon. If urine osmolality, on the other hand, is more than 100 milliosmol per kg, then the urine is not maximally dilute. Then you move on to look at your urine sodium and volume status. Next step, you look at sodium, urine sodium. If urine sodium is less than or equal to 30 millimole per liter. Some say 20, but we use 30. And the patient is obviously volume overloaded. You have no question the patient is volume overloaded. Then the chances are that your patient may have heart failure, CHF, nephrotic syndrome, or cirrhosis. This type of diagnosis is relatively unlikely to miss. Most people will be able to identify it. If urine sodium is less than 30 and patient is clearly volume depleted, you can see that the patient is volume depleted. And then there is generally a history of vomiting and diarrhea as well. And these categories are relatively less common. If urine sodium is more than 30 and the patient appears euvolemic, and in most cases plasma osmolality is low, typically less than 275, then you have two possibilities. Either most likely SIADH, or in rare circumstances, cortisol deficiency. So now we have come down, we have ruled out all the other, now we are coming down to SIADH. Remember, SIADH is a diagnosis of exclusion. Cortisol you can very quickly exclude. We published a few papers on that, so I think most of you may be aware of it. You check the morning cortisol. If the morning cortisol is more than 250 nanomole per liter, your cortisol status is normal. These people do not have adrenal insufficiency. If cortisol level is really low and your patient, and there's no other confounding factor like exogenous steroids or stuff like that, then your patient may have cortisol deficiency. And if you're in doubt, you can do a stimulation test. For the most part, this is something which is, again, relatively rare in my experience. SIADH, on the other hand, is the commonest reason, and we will generally, as I said, we will see that volume status is the patient is euvolemic, their urine sodium level is over 30, plasma osmolality is low, less than 275. And this is classically a diagnosis of exclusion. You've excluded all the other possibilities. Now what you are going to do is you essentially are going to start fluid restriction. Now fluid restriction is the mainstay of treatment. How much? There is a formula which is called FIRST formula, which is here on the right side. Essentially, you add urine sodium and potassium and divide that by serum sodium. If your answer is more than 1, this essentially means that your free water concentration or free water in the urine is actually already low, and the kidney is already trying to trying to conserve as much water as possible. So fluid restriction is not going to be very helpful. However, for the most part, what we like to do is we start them on fluid restriction. Fluid restriction means real fluid restriction, less than a liter a day. Because if you do less than that, most people generally don't respond well to fluid restriction. So acute fluid restriction of less than 1 liter a day may be needed, but it's very hard to sustain in the long run. What I tend to use, I try that. If that doesn't help, then I generally add, particularly if this is a long-standing problem, because with cancer it's a long-standing problem, I add oral salt tablets. It's 1 gram tablet, and you give 2 to 3 tablets or even more. You can add furosemide to it to increase your free water clearance, and that will bring your sodium level into a relatively reasonable range. In some patients where they have uncontrolled hypertension and sodium cannot be used, you can use urea tablets, and your pharmacist should be able to formulate these. They generally contain 15 grams of urea. The problem is that they can cause a pretty awful taste in the mouth, but that's what you would typically use. Demeclocycline can be added. It basically causes diabetes insipidus-like state, and leads to a correction of sodium. Some centers and some, particularly in the US, they have used vasopressin receptor antagonists like tolvaptan and others. We don't use it on a routine basis, first of all, because it requires a lot of intensive follow-up, and it's very expensive, so we generally don't use it. In terms of chronic hyponatremia, There is really no clear evidence to suggest that there's any benefit to treating, particularly if it's mild to moderate and even not in severe. Unless patient has symptoms, I generally watch them, and essentially we use judicious fluid restriction, maybe add a bit of salt and demeclocycline, but that is pretty much all what you need. Mostly these people do fine without any treatment. So in summary, the most common cause of hyponatremia in cancer is SIADH. If serum sodium is less than 120, or patient has symptoms, then treat right away without waiting for results. Avoid overcorrecting, and if it does happen, consider giving dextrose and DDAVP. Fluid restriction is the mainstay of treatment for SIADH. And if your urine-free water excretion is already low, then it won't work effectively, and use the first formula. Otherwise, you can add to it salt tablets plus furosemide or urea for symptomatic long-term treatment. And for the most part, chronic hyponatremia really does not require any specific treatment. Thank you very much. I hope this was useful. And if you have any questions, you can email me subsequently.
Thank you very much, Professor Ali Imran, for a very comprehensive talk on hyponatremia. As far as questions go, I've already got one question in the chat box. So I welcome all attendees to put their questions in the chat box, but our question and answer session will be at the end from 10:40 a.m. to 11 a.m. So that's when we'll be putting our questions to our speakers, who will hopefully be joining us live at that time. So with that, I would like to introduce our next speaker, Dr. Kiran Chaudhary, who's an assistant professor of pediatric endocrinology and a visiting consultant at Shalimar Hospital. She did her training at University of Illinois College of Medicine, and she's going to be talking to us about growth failure and how to manage that in cancer pediatric population.
Assalamu alaikum. Thank you for giving me a chance to talk about growth failure in childhood cancer survivors. I have nothing to disclose. My intent and hope from this talk is that at the end of it, you guys should be able to identify kids who are at high risk for developing growth failure after their cancer treatment, and be able to evaluate them and treat them. And as we go through the presentation, I will continue to point out some of the important clinical consideration that you have to keep in mind when taking care of such kids. So luckily, childhood cancers are not as common and overall have a good survival rate, with hematopoietic malignancies doing even better in this regard. But with the advancement of therapies, we are also seeing a lot of long-term complications in these patients, and endocrine disorders are on top of the list for them. Of course, there are many reasons for developing hormone abnormalities, like a patient's own genetic susceptibility, the type and location of the primary disease, and last but not the least, the treatment modalities. And of those, radiation exposure to endocrine organ continues to be the single most important risk factor to develop these hormone problems. And the hormone problems because of radiation are both dose and time dependent, which means that the higher the radiation dose and longer the time since treatment, the higher the risk of developing these hormone abnormalities. So this slide shows you the prevalence of pituitary deficiencies in adults who were childhood cancer survivors and also received intracranial radiation. And you can see that although the multiple pituitary hormones deficiencies are quite common, growth hormone deficiency is the most common abnormality in such patients. And this slide shows you the same issue, that as we move away from the diagnosis, the risk of the hormone abnormalities continue to rise. So patients who have a tumor in the hypothalamic pituitary region either may present with hormone abnormalities or may develop them soon after surgery. And we have all taken care of kids with triphasic vasopressin triphasic response from vasopressin release, and many of them go on to develop central DI. But it also shows you that growth hormone deficiency is quite common even with lower doses of intracranial radiation. And as the dose of radiation increases, the risk of hormone abnormalities also increases with it. So like I mentioned earlier, cranial radiation, it results in more anterior pituitary disorders, but craniospinal or total body radiation not only causes growth hormone deficiency, but may also cause skeletal dysplasia because of impaired growth of the spinal column. Chemotherapeutic agents like TKIs or retinoids may also affect growth by affecting the signal transduction of growth hormone or causing earlier closure of growth plates. This is a very simplistic picture of growth hormone axis. As you know, growth hormone releasing hormone comes from the hypothalamus, goes to the somatotropes in the anterior pituitary where growth hormone is produced, which in turn goes to the liver and leads to production of insulin-like growth factors and the binding proteins, which goes to bone and soft tissues and contribute to growth. So coming to the topic on hand, like we said, growth hormone deficiency is frequently the most common and only hormone deficiency in children who have received intracranial radiation, and the effect of it is long lasting, with a lot of these children ending up with adult short stature anywhere from 9 to 40%, depending upon the type of tumor and the amount of radiation they received. Some terms for people who don't typically take care of children. The short stature is defined as height that is less than 2 standard deviation for age and gender matched normative data. We typically use CDC or WHO curves, but there are country-specific growth curves as well. And if there is one available for that particular child, for that country, they should be plotted on it. Growth failure is either a growth velocity which is less than 5th percentile for age and gender. For example, we expect a prepubertal child after the age of 5 to grow at least 5 centimeters per year. And if they are not doing that, then they would be considered in growth failure. Similarly, in a child who has not completed their growth, if they start dropping on the height percentiles and drop more than 2 of those, then they are also considered in growth failure. Some risk factors for poor growth in childhood cancer survivors are, of course, malnutrition, genetic short stature, or presence of some other syndromes like Noonan syndrome, Down syndrome, or Turner syndrome. Moreover, drugs that may contribute to short stature, the primary tumor location and the surgery that might affect the hypothalamic pituitary axis, and last but not the least, the radiation to the spinal column. So this is, I think, is the most commonly used and most famous graph showing the decline of growth hormone secretion with the increasing dose of radiation. As you see that as the dose of radiation to the hypothalamic pituitary area increases, the peak growth hormone level decreases, and it continues to stay low even years after the treatment. And that was also stressed on the long-term follow-up guidelines by COG, where they recommend that any child who had received intracranial radiation or total body radiation should be assessed every 6 months for both growth and pubertal status, and children who have received higher doses of intracranial radiation should be sent to a pediatric endocrinologist earlier on. Some important consideration while taking care of these children is that Sometimes intracranial radiation will cause growth hormone deficiency, but also precocious puberty. And in those cases, you may not notice growth failure in the beginning. And in fact, if you check their IGF-1 level, the IGF-1 level may come back low normal and give you a false assurance that everything is okay. And a lot of us have been burned in our earlier career because of that. So I just wanted to point that out to keep in mind about the growth in children who have precocious puberty, and also not to rely on IGF-1 level in such cases. Also, children who have or will have poor growth because of radiation to their spine, you may not see them or you may not pick up on that earlier on, and they will present to you with growth failure more close to the puberty when the growth spurt does not happen because the spinal growth is impaired. These kids typically have asymmetrical growth when the limbs continue to grow, but the torso doesn't grow. And while the children who have growth hormone deficiency have more symmetrical growth, short stature. Also, the abnormality, the radiation to the spine also causes spinal abnormalities like scoliosis and kyphosis, and that also contributes to short stature. So here you can see a person who had radiation to their spine and their torso continued to stay short. And that also includes the cervical spine as well. But their limbs grew. But then here is a child with growth hormone deficiency who is just proportionately short. So what about children who received treatment for cancer but did not receive intracranial radiation? So in children who are childhood cancer survivors of ALL and didn't receive radiation, we know that while they were receiving the chemotherapy, they did have a decline in their growth velocities, but many studies show that they had a catch-up growth and ended up being within 2 standard deviation of the mean for their population when they were adult. But there are also some studies that show that in such patients, there is a 3 times increased risk of being a short adult as opposed to the children who were not treated with cancer, any kind of cancer medications. Another important point for special cases like craniopharyngioma or people who have hypothalamic tumors, that these patients may develop excess weight gain soon after surgical resection. And even in cases of documented growth hormone deficiency, their linear growth may not be low. It can be normal or even high. And etiology of that is not known. The most common theory that is given is that because these children develop insulin resistance and high insulin level go on to work on IGF-1 receptor and contribute to linear growth through that. So when to suspect growth hormone deficiency or short stature in your patients, if you see a growth chart like this, where a child is dropping on height percentile, but maintaining their weight or actually having an increased weight gain, this is usually indicates an endocrine problem. So that should be sign enough for you guys. But in cases where you don't have the luxury of growth chart, or the child presents to you around puberty where you don't have the previous marks, then you can also look at the symptoms of growth hormone deficiency as you would in an adult, like decreased muscle mass, low exercise endurance, dry skin, increased weight gain, etc., to warn you that this might be a growth hormone deficiency patient. So you already have a patient, you suspect they have growth hormone deficiency, and now how to evaluate them. So when we get patients who are childhood cancer survivors and they are coming to us for growth deficiency, we evaluate them like we would for any other child who doesn't have that particular past history. Physical examination is very important. Fun hairdos and the clips and hairs are lovely, but it should not interfere with accurate height assessment. Pubertal status should be assessed at every visit, and I cannot stress the importance of growth chart in such kids. We do check growth factor, thyroids, and bone age, and I will talk a little bit about growth hormone stimulation test as well. And like I said before, we assess them like we would for any other child who would come with growth failure. So bone age tells us about the skeletal maturation, and we also use bone age to predict the final adult height. For some reason, whenever I have gotten bone age or in Pakistan, I usually get only the wrist view. You actually need to have the whole hand to be able to make accurate assessment of the skeletal age. So please stress that to your radiologist that you need to look at the whole hand from distal phalanges to all the way to the wrist bones. The growth hormone stimulation test is the gold standard to diagnose growth hormone deficiency. If you are going to do this test, it should be done properly and followed a proper protocol, because the interpretations of the growth hormone deficiency are based on certain particular protocols. The most common agents that are used are glucagon and clonidine. Insulin can be used, but there is a risk of hypoglycemia, and a lot of people try not to use it in pediatric population. The cutoff is less than 5 microgram per liter for growth hormone deficiency. You also have to keep in mind that it may only detect the deficiency in growth hormone production. It does not really look at the neurosecretory defects. Also, children who are in the pubertal age but are not showing any signs of puberty should have sex steroid priming before their growth hormone stimulation test is done to avoid any false negative. Despite the fact that it's considered gold standard, growth hormone stimulation test is not a very good test. It has poor reproducibility, and the assays for growth hormone have a lot to be desired in their standardization. Some consideration about this particular test. You don't need to do growth hormone stimulation tests in children who have more than 3 pituitary deficiencies. So if your child has multiple pituitary abnormalities, it's very likely that they already have growth hormone deficiency. Also, like I mentioned earlier, that do not use IGF-1 as the screening tool or the only diagnostic tool for diagnosing growth hormone deficiency, especially in the cases of precocious puberty. Also, please don't use random growth hormone level. I get those a lot of times in children who are referred to me for short stature or with the worry of growth hormone deficiency. The random growth hormone level does not mean anything. It's an expensive test and should not be done. It gives us zero information. And as in any other cases, when children who have isolated growth hormone deficiency in childhood become an adult, they should be retested to see if there is an ongoing need for growth hormone. Endocrine Society also recommends doing a sitting height along with the standing height in children who are at high risk for spinal abnormalities, especially children who have gone through craniospinal or total body radiation or have prolonged steroid treatment as well. That's how you do accurate standing height with the stadiometer. With this back, the hips and the feet touching all the way and shoulder straight, and the person who is checking the height should be at the eye level. Same thing for the sitting height, should be done sitting down with the straight spine to the back. That's how the reason we want to do upper and lower segment ratio is to see if there is any disproportionate growth, because that's important later on when you are considering treatment and the prognosis of treatment as well. So you have evaluated your kid and you feel that the child has growth hormone deficiency. So should we go ahead and start him on treatment. One thing to keep in mind is that when deciding about treatment, the most important thing is the growth pattern and not just the blood work. So even if your child has low IGF-1 level, fails the growth hormone stimulation test, but is growing okay, you may not need to start growth hormone on that child. Also, I don't think I've ever started a child on growth hormone without talking to their oncologist, because you need to know a lot of information: what kind of tumor the child had, what is the risk of relapse, what is the overall prognosis for that child, and also the goal and wishes of the patient and the caregiver should be respected. Sometimes, even if the child is short or is going to be short, the parents don't want growth hormone. They don't want another in medicine that is a daily injection for several years. And sometimes they want growth hormone immediately after treatment. So all those things need to be kept in mind. Also, when you are talking about growth hormone therapy, remember that the height is not the only aspect. There are other metabolic effects of growth hormone as well that should be told to the patient and the family when you are having that discussion. So when should you start treatment? I think that's the golden question, and there is no scientific answer to that. In 2018, the Endocrine Society came up with a recommendation, and they suggested waiting 1 year after being disease-free to ensure that there is no early recurrence. A lot of centers don't wait that long for craniopharyngioma, and it usually started on growth hormone within a year of diagnosis or within a year of surgery or whatever their treatment modality was. The doses of growth hormone is typical as you would use in a child who doesn't have a history of cancer. And for people who use IGF-1 to titrate their treatment, the IGF-1 should be maintained within age and tenor stage appropriate level. So, in response to growth hormone therapy, this is one of my patients who had nasopharyngeal tumor and received intracranial radiation. He actually had multiple pituitary abnormalities and initially had a very low growth velocity, about 2 to 3 centimeters per year. And I didn't need a arrow here to show you where growth hormone was started. And he had a remarkable response, so much that I had to continually decrease his dose to keep his growth velocity around 12 centimeters per year and his IGF-1 in the upper third of normal. A little reminder about the treatment prognosis, that children who have growth hormone deficiency only, like my patient, may actually have a quite impressive response and improvement in their final adult height, and grow very well in the first few years of growth hormone therapy. Children who have craniospinal radiation or total body radiation, their response to growth hormone is very unpredictable. They can have improved final adult height, or growth hormone may not work at all, or in some cases may actually make the proportionality of their stature worse by making their limbs longer and torso short. So this slide is for the fellows in particular. As you progress in your career, you all will make your own spiel when you are starting somebody on growth hormone therapy. There are some studies that you should know, because those questions come up again and again. And I have summarized a few, and the rest are in the references. But I'm going to just go over some common questions that we've faced when we are talking to the patients about starting growth hormone. So the first one is there increased risk of secondary tumors with growth hormone treatment? So in the past, we used to think that there is increased recurrence of meningiomas and gliomas in patients who received growth hormone therapy. But the most recent updated analysis of childhood cancer survivor study showed that there was no association between growth hormone therapy and development of subsequent cancers after a long follow-up. Secondly, does IGF-1 increase the risk of cancer? There were some meta-analysis that showed that higher IGF-1 levels were associated with prostate, colon, and I think breast cancer as well. But more recent studies have not shown that association. I do get this question asked a lot, that in patients who have had cancer before, should we keep an IGF-1 low normal? There is actually no data that suggests that keeping an IGF-1 in the low or normal range will decrease the risk of malignancy. I feel if you are treating these patients, you should treat them properly and keep IGF-1 level in the upper third of normal for age and gender. Age and pubertal status, sorry. Is there, so recently there has been a lot of interest and a lot of questions about the risk of leukemia with growth hormone therapy. St. Jude's published a report in which they reviewed about 1,000 kids who were treated with ALL, and they compared children who had leukemia, who had growth hormone therapy and who didn't receive growth hormone therapy, and they did not see increased risk of relapse in patients who received growth hormone therapy. Also, a lot of patients ask that if they do growth hormone treatment now, would that increase the risk of cancer later on when the child is an adult? And that concern comes from a study done in UK, in which they looked at about 1,300 pediatric patients who received growth hormone and compared them to children who didn't. And they saw that the group that received growth hormone had double the risk of colon cancer. But there were actually only 2 cases in the group that received growth hormone. So statistically, it's a significant result because the risk is double. But there were only 2 cases, and one of them were already a high-risk patient. So for those who are more visually inclined, growth hormone deficiency should be suspected in any child who has received intracranial radiation. They should be monitored closely with height and pubertal assessment every 6 to 12 months. IGF-1 should not be the only test to diagnose growth hormone deficiency. No need for growth hormone stimulation testing if a child has multiple pituitary abnormalities already. The treatment with growth hormone can be started in a child who has been disease-free for at least a year after completing treatment. People who have stable disease are not considered completely disease-free can be given growth hormone by discussing that with their oncologist and assessing the risk overall. Also, the efficacy and the monitoring of growth hormone therapy in these children is same as you would in a child who does not have a past history of childhood cancer. I think that's end of my presentation. I would love to take questions at the end of the session. Thank you.
Thank you very much, Dr. Kiran, for a very interesting and informative talk. Pediatric endocrinology, growth failure in cancer patients is obviously a very important topic at any cancer hospital, as it is at ours. Again, I would like to remind all the attendees, if you have any questions, please type them in the chat box, and we will be asking all our speakers those questions live at the end of the session. Now I would like to introduce our next speaker, Dr. Ahmed Imran Siddiqui, who's a consultant endocrinologist at Shaukat Khanum Hospital. He did his clinical training in diabetes and endocrinology from London and is a fellow of Royal College of Physicians, London, Edinburgh, and Glasgow. And he's going to be sharing a few interesting clinical cases from our endocrine oncology clinics here at Shaukat Khanum.
Assalamu alaikum and a very good morning. I'm Dr. Ahmed Imran Siddiqui. I'm a consultant in diabetes and endocrinology here at Shaukat Khanum Hospital, Lahore. It's a great pleasure for me to be part of presenting team at this wonderful symposium of Shaukat Khanum, and I would like to thank the organizing committee for giving me an opportunity to present some interesting endocrine cases which I met in my clinic. This is Shaukat Khanum Hospital, Lahore, and I'm sitting here presenting the cases from here. I really like this view of the lake, and if any one of you get a chance to visit Shaukat Khanum, Lahore, I would strongly recommend this view to you. My first clinical case is a 32-year-old lady. She presented to pulmonology clinic with symptoms of cough, hemoptysis, and weight loss for the previous 4 years. She also had amenorrhea for a year, and there was no history of galactorrhea, headaches, or visual disturbances. Family reported a gradual change in her facial appearance, and she had never smoked in her life. There were subtle acromegalic features noticed in the clinic, and there were prominent supraorbital ridges, there was wide nasal bridge with coarse facial features, and the visual field examination of the patient was normal in the clinic. The clinical assessment then led to imaging investigations, and the most obvious next clinical investigation with this history was the CT scan of the chest. The scan showed right mainstem endobronchial mass. We then did a biopsy of the mass, which confirmed neuroendocrine tumor. Following the confirmation of this diagnosis, the patient underwent a series of imaging investigations, which we call tumor staging workup, and during those we found a pituitary macroadenoma. The patient then ended up having a dedicated MRI scan of the pituitary gland, which showed a pituitary macroadenoma, largest dimension 2 centimeters. It was extending into suprasellar region with mild to moderate optic chiasm compression. So here I share the MRI image with you, which is showing that the pituitary gland is smoothly enlarged, and it looks rather globular in appearance, and the largest dimension that we said is 2 centimeters. Imaging investigation was followed by biochemical investigations. And as you can imagine, that once you find a pituitary macroadenoma, in addition to a neuroendocrine tumor in the chest, you are going to check the parathyroid hormone levels. The biochemical investigations confirmed a high IGF-1 and prolactin level. And in addition, the parathyroid level was high with low vitamin D and low normal calcium. Now, this result could suggest secondary hyperparathyroidism, because the vitamin D is low and the calcium is also at the lower end of the normal range. However, the possibility of primary hyperparathyroidism is there. We then formulated a list of possible diagnoses, and the one was possibility of bronchial neuroendocrine tumor with hyperparathyroidism and growth hormone secreting pituitary adenoma. If all these three diagnoses are there, then it's likely multiple endocrine neoplasia. The other possibility was that these tumors were not related to each other. So it was a bronchial neuroendocrine tumor with an incidental pituitary adenoma and secondary hyperparathyroidism. The third possibility, however, was that bronchial neuroendocrine tumor was causing pituitary hyperplasia with excessive secretion of growth hormone releasing hormone, and in addition to that, patient has got secondary hyperparathyroidism. Well, whichever of the three was the most likely diagnosis, the next step in the management was going to be the surgical removal of the neuroendocrine tumor. And that's exactly what we did. And there were no surprises on histology or staining of the surgical specimen. It was a neuroendocrine tumor grade 2 with standard stains for the neuroendocrine tumor. Once the treatment was completed for the neuroendocrine tumor, patient has a recovery phase, and we then completed the vitamin D replacement. Following replacement of vitamin D, the parathyroid hormone and calcium level both got well within the normal range. Now that confirmed the diagnosis of secondary hyperparathyroidism, and the possibility of diagnosis of primary hyperparathyroidism was excluded. We then did an MRI scan of the pituitary gland, and the scan 4 months later showed that the pituitary macroadenoma, at least what we thought was a macroadenoma, was also smaller in size, now 1.6 centimeters in the largest dimension. We completed the investigation with a biochemical profile, and notably, IGF-1 had completely normalized, while prolactin was almost getting within the normal range. I shared these images with you, that the one on the left labeled A is the one which was at the time of presentation, and the one on the right, which is labeled as B, is the one 4 months later. You can see the difference in size of the pituitary gland and significant improvement over the 4 months. We then completed further biochemical investigations and imaging investigations. However, I have chosen the 18 months timeline because that's when the pituitary gland had completely normalized. I shared these images with you, showing the coronal and sagittal sections and confirming that the pituitary gland has completely normalized. This takes us back to our initial slide of possible diagnosis, and I have now rearranged the diagnosis with the bronchial neuroendocrine tumor secreting growth hormone releasing hormone, leading to pituitary hyperplasia with excessive growth hormone production and secondary hyperthyroidism as my main diagnosis. We did not confirm the biochemical presence of growth hormone releasing hormone, but with the high IGF-1 levels, this is the most likely explanation, especially in the presence of pituitary hyperplasia. Now, the other diagnosis we had was the bronchial neuroendocrine tumor secreting growth hormone and incidental pituitary adenoma. However, an incidentaloma of the pituitary gland would not regress in size or disappear with the treatment of bronchial neuroendocrine tumor. So that's excluded of the possible diagnosis. The other third possibility was of primary hyperparathyroidism, which was not the case as it got corrected with vitamin D replacement. So this remains our main diagnosis of pituitary hyperplasia with growth hormone releasing hormone from the neuroendocrine tumor, in addition to secondary hyperparathyroidism. The learning points from this case are that the ectopic secretion of growth hormone or growth hormone releasing hormone should be considered in patients with proven growth hormone excess and another tumor. Also, ectopic secretion of growth hormone or growth hormone releasing hormone should be considered in patients with confirmed acromegaly when we do not have a clear source of secretion of growth hormone or growth hormone releasing hormone from pituitary gland. Now, some of you in the audience who are completing their training years may find this easier if we go through the normal physiology first. So the growth hormone releasing hormone from hypothalamus stimulates the pituitary gland to produce growth hormone, which then produces IGF-1. The IGF-1 then sends the negative feedback messages to somatostatin receptors, which then inhibits the release of growth hormone. Here in this case, the balance has been shifted in favor of growth hormone releasing hormone, which is being produced in large volumes from the neuroendocrine tumor, which then led to hyperplasia of pituitary gland and excessive production of IGF-1. Here I complete my first case, and I leave you with the image of Shaukat Khanum, Peshawar. So Shaukat Khanum, Peshawar is a beautiful new building, state-of-the-art, with all the facilities, particularly useful for the population in the north of the country. Okay, we make a start of our second case here, who is a 19-year-old teenager. And the patient presented actually to his local doctor with some visual problems. In addition, he was complaining of symptoms of generalized tiredness for the previous few years. There were really no signs of puberty, and the patient looked a lot younger than his age. He was not getting involved in physical sports, and family noticed a general decline in his health over the previous few years. The local doctor referred him in view of his visual symptoms to ophthalmologist, who completed a thorough examination and confirmed bitemporal hemianopia. I haven't got the images with me right now, but that was showing right at the top of both temporal upper quadrants that there was some visual loss. With this finding, the MRI scan of the pituitary gland was completed, which showed a pituitary adenoma abutting the optic chiasm. The patient was then referred to the neurosurgical team and endocrine clinic. Here I share the MRI scan of this patient at the time of presentation. You can see the both coronal and sagittal views. Once again, this reminds us of the first case, which is smoothly enlarged, globular-looking pituitary gland. I then take you to the biochemical investigations of this patient. And I give you a minute to go through the investigations, but the interesting thing is that almost all the pituitary hormones, they look low. However, the TSH is significantly high. So we are dealing with a situation where you have very much pan-hyperpituitarism, except profound primary hypothyroidism. With these findings, we then completed an insulin tolerance test, which showed an adequate response for cortisol and growth hormone. So the possible diagnoses in this case then are pituitary adenoma with pan-hyperpituitarism and primary hypothyroidism, or primary hypothyroidism leading to pituitary hyperplasia affecting other pituitary hormones. Now, whichever of the two was the diagnosis, the important thing here is the patient has already got very early bitemporal hemianopia, and the patient requires treatment sooner rather than later to avoid visual loss. We all know in the endocrine clinics how important is that, and time is very important in this scenario. We discussed the patient in the multidisciplinary meeting, and we also discussed with the patient the possibility of pharmacological intervention or surgery. Reviewing the images in the meeting and the primary hypothyroidism picture and a normal insulin tolerance test, we felt that hyperplasia was a real possibility in this patient. And we decided to go ahead with thyroxine prescription. At the same time, we decided to monitor the visual fields, and if there was any worsening in the visual fields, we decided to then go for the surgical option. The patient was prescribed thyroxine 25 micrograms once a day. The dose was then increased to 75 micrograms once a day 3 weeks later. The visual field assessment at that time, most importantly, did not show any worsening of the visual fields. The improvement was not really noticeable at that stage. We kept the dose of thyroxine at 75 micrograms once a day with improvement in the blood tests of the patient. I've chosen the timeline of 3 months, although we did some blood tests prior to that as well, because that's when we noticed significant biochemical change in his blood tests. So have a look at that 3 weeks later blood test, that there was not any significant improvement, but patient was taking only 25 micrograms of thyroxine at that time, and the free T4 was just about detectable at that level. However, 3 months later, it seems the biochemistry has completely normalized. Thyroid functions are normal, IGF-1 is normal, testosterone and gonadotropins are normal, and prolactin is almost getting to the normal range. So in 3 months' time, we achieved biochemical normality, if I can use that term. So here we compare the scans at presentation, the one on your left labeled A, and the scan in 3 months' time. There has been a significant improvement in the pituitary gland, although we can still see that it is not completely normal. 10 months later, the biochemistry, as we already said, had normalized in 3 months, so it remained good at 10 months. And the imaging at that time has shown significant improvements with almost normal pituitary gland. So here I share all 3 images which we have so far seen with improvement over previous 10 months. The pituitary gland has significantly regressed in size, although it looks as tiniest of the adenoma or persistent hyperplasia. So going back to the slide of the diagnosis, which is either pituitary adenoma with panhypopituitarism and primary hypothyroidism, I don't think that's a diagnosis because adenoma would not regress in size with thyroxine, so that's not the diagnosis. This seems to be the most likely diagnosis, which is the pituitary hyperplasia due to primary hypothyroidism. However, we also discussed the possibility that since 10% of the population has got incidentaloma, either we need to wait a bit longer for the pituitary gland to completely settle, or the patient may have got an underlying small pituitary adenoma, which may never settle. The treatment, however, in both these cases will remain the same. Once again, some of the trainees in the audience may benefit from that in this case, we believe that the thyroid hormones not being produced are not sending the negative feedback signal to TSH or TRH. The TRH persistently stimulated TSH cause pituitary hyperplasia because it is not getting the negative feedback. Once the thyroxine was replaced, the negative feedback stopped production of TRH, TSH normalized, and hyperplasia settled. So a complete biochemical investigation, including pituitary biochemical profile, is essential prior to management decisions related to pituitary gland lesions. Also, pituitary hyperplasia should always be considered a possible diagnosis in appropriate clinical scenario. Well, I think with these two cases, I have made enough of a case to consider that a possible diagnosis in these scenarios. I leave you with the model of Shaukat Khanum, Karachi, and let you catch your breath before I start my third case. Right, so that's the model of Shaukat Khanum, Karachi, and that is currently being built. This is the third of the Shaukat Khanums, and we are excitingly looking forward to its completion. Now I start my third clinical case with a 55-year-old lady. She had a long-standing neck swelling in front of her neck. However, she never sought clinical assessment or investigations because it was not giving her any problems. The swelling kept increasing in size gradually until recently, which she described previous few months, it started to get worse significantly. She also started to notice some breathing difficulties, especially in lying flat, and that was the main reason that she started looking for treatment for that. There were no known risk factors for thyroid cancer, like radiation exposure or family history. So it was a large swelling in front of her neck, more on the right side. It had retrosternal extension. There were few enlarged cervical lymph nodes. There were no signs of eye disease, and there were no added PET scans. So she attended a local hospital with these symptoms, and they did a core biopsy of the mass. The biopsy specimen was sent to Shaukat Khanum Hospital, Lahore, and the lesion confirmed that it was medullary thyroid cancer. Patient was then referred to the Shaukat Khanum Hospital for further treatment, and you can see the patient had standard biochemical investigations, which is suggestive of sporadic medullary thyroid cancer with normal metanephrine and norepinephrine, normal parathyroid and calcium levels, along with normal thyroid functions. But the most interesting thing was normal calcitonin and CEA levels. You would not expect normal calcitonin in a patient with medullary thyroid cancer. So we repeated the test as you would expect, and the results were once again showing both of these within the normal range. We then completed an MRI scan of the neck, which showed a sizable lesion, 8.5 centimeters craniocaudally, reaching up to carina. She then had a CT scan of the chest, abdomen, and pelvis. There was no evidence of lesion elsewhere in the body. So here I share the axial section of that mass, which is marked with these white arrows. It's a heterogeneous mass, as you can see. The bone scan was completed as part of investigation for medullary thyroid cancer, which showed no evidence of metastasis. And we then completed a CT angiogram to see the resectability and the vascular involvement. And as you can see, for the 360-degree encasement of the right common carotid artery, And then it was 180-degree encasement at the level of thyroid gland. So here I share the image with you. And based on the resources available in our center, the tumor cannot be resected with the vascular involvement. The biopsy then had the stains, but the most important of these are negative calcitonin and negative CEA stains, which is unusual for medullary thyroid cancer. However, the diagnosis of medullary thyroid carcinoma was confirmed on the morphology of the cells, which we could see under the microscope. So the differential remains either it is a calcitonin negative medullary thyroid cancer, or it's a neuroendocrine tumor with metastatic deposit in the thyroid gland. We have already said that the CT scan of the chest, abdomen, and pelvis had shown us that there were no deposits elsewhere in the body, and the sample was taken from the thyroid gland lesion. So calcitonin negative medullary thyroid cancer remains the diagnosis in this case. So a few interesting points about the calcitonin negative MTC I just found in the literature. Calcitonin is 32 amino acids, a linear peptide produced from the parafollicular cells of thyroid that make 1% of the thyroid gland. Importantly, from the clinical point of view, we use calcitonin for the diagnosis or assessment of treatment response and monitoring of recurrence of patients with medullary thyroid cancer. There were more than one explanations in the literature about the reason for the loss of calcitonin production in these MTC, but the most likely explanation was the loss of function, which you can expect in malignant cells. In one of the series, the prognosis of calcitonin negative MTC was divided into distinct groups, extending up, going up to 12.5 years or less than 2 years. However, there were no definite markers or findings which you could use in the clinical setting to identify these two kind of patients, other than just to see aggressive nature of the disease, which would make you think that they may have got a shorter prognosis. Interestingly, in another group of patients, case series of calcitonin negative MTC, according to that series, the prognosis of calcitonin negative MTC was better than the calcitonin positive ones. I think the numbers I could find in the literature, there were only like 50 total cases, and the complete details were also not available for all of them. And it becomes very difficult and challenging to reliably interpret the findings if the numbers are this small. So in our patients, the surgical treatment, as we said, was not an option because of vascular involvement. We are now considering radiotherapy as the next line of treatment. The treatment in calcitonin positive and calcitonin negative MTC, however, remains surgical. However, the follow-up will become more challenging in calcitonin negative patients because you wouldn't have calcitonin for follow-up. So different case series and case reports have mentioned for calcitonin, chromogranin A, calcitonin-related gene peptide, and all sorts of imaging investigations to follow these patients up for possible recurrence. We, in this particular case, did not get to that stage, so we didn't check any one of these for this patient. So the learning point is, I think in this case, and in general, we are sitting in a cancer center. So early detection and diagnosis is very important for curative treatment of any sort of cancer. And in this case is a good example of that. The other thing is that the calcitonin negative thyroid cancers are a rare diagnosis. However, we should all be aware of that and should consider in the list of differential diagnoses in appropriate clinical setting. With that, I would like to acknowledge my colleagues who helped me in completing these slides and completing this presentation. Short list of references, and I would like to thank you all for joining me here today. We can discuss this further in the question and answer session, and I will be happy to welcome your questions there. Thank you.
Thank you, Dr. Ahmed Imran. Great cases, very informative, different ways of approaching different endocrine oncology cases. So we can talk about this further in the question and answer session, and I'm sure if there are any questions, we'd be happy to take them. So I'm going to be introducing our next speaker, Dr. Richard Quinton, who's a consultant endocrinologist at Newcastle upon Tyne Hospitals, UK, and a senior lecturer at the Translation and Clinical Research Institute over there as well. And he will be talking to us about fertility in hypogonadotrophic hypogonadism. And this, again, is another very important topic, especially in our cancer population patients where fertility can potentially become an issue post-treatment.
So many thanks for the invitation. I'm only sorry I can't be with you in person, and also sorry I can't even be with you virtually in person, this being early in the morning in the UK, and this being my birthday. So happy birthday to me. My name is Richard Quinton, endocrinologist in Newcastle upon Tyne, at the hospital and at the university. And first of all, a big hello to my friends and colleagues in Pakistan, former trainees of mine, and also colleagues I've previously met at various Pakistan Endocrine Society meetings. So today we're going to talk about fertility in hypogonadotrophic hypogonadism, and you'll forgive me if I concentrate more on congenital hypogonadotrophic hypogonadism, because that's where things are more difficult and more challenging. So in this presentation, I talk about the physiology of the male reproductive axis, the ontogeny, hypogonadotropic or central hypogonadism, congenital versus acquired, to give you a kind of sperm induction cookbook for hypog, and thinking about whether we can improve outcomes through smarter use of the same old drugs. And this will be interspersed with illustrative clinical cases. This is the science bit. I promise you this is the only science bit slide. So let's start actually with the testes. And we can see here that the Sertoli cell, the kind of nurse cells of the testes, are responsible for each Sertoli cell can nurse 4 germ cells into the process of becoming mature sperm. But Sertoli cells require hormonal stimulation to do this. They require FSH from the pituitary, and they require insulin-like factor 3 and testosterone from the Leydig cells. And testosterone is stimulated by pituitary LH. And remember, the levels of testosterone in the testes are far, far higher, perhaps up to 100 times higher than those in the circulation. So this is kind of paracrine action of testosterone within the gland, and this is endocrine action of testosterone in the circulation. Now, what determines pituitary LH and FSH? Well, this is GnRH neurons in the medial basal hypothalamus. But what drives them and what motivates them, these are the Candy neurons in the arcuate nucleus, acting on the GnRH neurons via the peptides urocinin B and kisspeptin. And what determines Candy neuron secretion? Well, there's negative feedback from sex steroids, and there's also all kinds of internal and external homeostatic signals, also involving leptin from adipose tissue, which is required to keep the axis active. So if you lack testosterone, if you've got congenital hypog, and you get to age 25 untreated, this is kind of what you look like. But with testosterone, this is what you can achieve. Although what you can't achieve is sperm. So exogenous testosterone can make you a fully mature man. It is not enough. It cannot make you make sperm. That requires both FSH and it requires paracrine, Leydig, LH stimulated testosterone from Leydig cells within the testes. Just to give you a kind of a brief intro to different male and female differences. It's not just all about the ability to multitask or parallel park. So females, even in utero, female fetuses already have their lifetime supply of ready-to-go oocytes already there, whereas males have to go through 3 distinct phases of testicular maturation, beginning in utero and ending with puberty in order to develop and sustain normal spermatogenesis. So there's this triphasic maturation of the testes, which begins with external male sex differentiation from gestational week 7, followed by mini puberty, which begins around 8 weeks before birth and completes 6 months postnatally. And then finally at puberty, where there's completion of germ cell proliferation and differentiation. External male sex differentiation, this results from placental HCG driving the Leydig cells to secrete testosterone. And at the same time, the GnRH neurons are migrating from their origin in the nasal placode to their final position in the hypothalamus, and they're migrating along fascicles of the olfactory nerve. So mini puberty, this is where there's a burst of fetal and neonatal GnRH secretion, beginning prenatally and continuing for up to 6 months postnatally, driving pituitary FSH and LH, and giving rise to LH, FSH testosterone levels that are kind of adult mid-puberty range. This results in germ and Sertoli cell proliferation. However, there's no cell maturation or sperm production because the Sertoli cells don't actually express the androgen receptor until age 5 years. So there's no interstiticular paracrine action at this point. And finally, at puberty, FSH and paracrine testosterone induce germ and Sertoli cell maturation, seminiferous tubercle formation, and spermatogenesis. Of course, spermatogenesis can't occur during mini puberty, obviously because the Sertoli cells can't see testosterone at that point. Therefore, little boys may have acne, they may have morning erections, their testes do increase in size up to 6 months of age, but they don't make sperm. And this just illustrates that the Sertoli cells, the nerve cells, the testes, and the immature Sertoli cell makes AMH, but under stimulation from FSH and from Leydig cell-derived testosterone, they mature, and production switches from AMH towards inhibin B, and that can they're sports spermatogenesis. You think about putting exogenous testosterone into the system or anabolic steroids if a patient was abusing testosterone, and of course you turn off pituitary LH and FSH through negative feedback. You thereby lose Leydig cell stimulating testosterone, and actually the exogenous testosterone causes your interstiticular paracrine testosterone levels to crash, and along with the reduction in FSH signal, that shuts down spermatogenesis. So male hypogonadism, we classify it as primary gonadal dysfunction, which I talk about as being the light bulb broken, and lack of LH and FSH stimulation, central or hypogonadotrophic hypogonadism, which I characterize as the light switch is off. In the first case, there's not much hormonally you can do about fertility. You're relying on the skills of your andrologist or donor sperm or adoption. But in the second, actually, you can actually restore the hormonal milieu by putting gonadotrophins back in again. How easy that is to do depends very much on the point of onset of central hypogonadism, whether it was congenital, so mini puberty never happened, or whether it was acquired, and whether it was acquired pre-puberty or post-puberty. And obviously, the later it was acquired, the easier it is to get the system working again with gonadotrophins. So this is a schematic of the male reproductive axis, its activity across the male lifespan. And we can see that we begin with HCG-driven testosterone secretion from 7 weeks. And if that is not functional, you may appear externally female, or DSD 46XY, maybe with hyperspadias. Then we have fetal GnRH secretion from 8 weeks prepartum. And if that isn't there, then you may well be born with microphallus or cryptorchidism, which is very common in boys with congenital hypoc, including Kalman syndrome. Then the axis is quiescent during childhood, and then it wakes up at puberty, either early, normal time, or late, and it stays active throughout adult life in general. So if your puberty fails to kick off, you may present with absent sexual characteristics, you may develop unicorn proportions, gynecomastia, and your testes will remain small. And if you are either undiagnosed for longer, or if you develop hypogonadism later in life, the issues are often a little bit different, including reduced libido, reduced bone mass, reduced muscle mass, reduced energy levels, anemia, and infertility. So the differentiation diagnosis of male central or hypogonadism for hypogonadism, first of all, you need to consider structural causes. Traumatic brain injury, civilian trauma tends not to cause much of hypopituitarism. It's much more common with military blast trauma. Then your genetic congenital causes, such as Kalman syndrome or combined pituitary hormone deficiency. And then your kind of functional or reversible causes, including constitutional puberty, systemic illness, extremes of weight. So we know that obesity tends to blunt the male reproductive axis, which is actually relatively protected against weight loss or excessive exercise, but that can still happen. Whereas the female axis is not shut down with obesity, but is probably more predisposed to shut down with exercise or weight loss, called hypothalamic amenorrhea. Similarly, corticosteroids tend to shut down the male axis, but tend not to shut down the female axis. Dopamine antagonists, anything that raises your prolactin level, opiates, androgens, and anabolics. Important to recognize, you're given a patient with male hypogonadism, and the first question I always ask is, well, was the diagnosis actually right? Because there's huge amount of scope to misdiagnose it. You can do a venipuncture in the afternoon clinic or after lunch. Only accurate really if it's done fasted after overnight rest, 9 AM sampling. If you do the bloods during systemic illness, physical or psychiatric, it's normal for the axis to shut down with any form of illness. If you look at men with obesity and insulin resistance, you may find that total testosterone may be low. However, the free testosterone may actually be normal due to the low levels of sex hormone binding globulin, as in this famous character. And also abuse of androgens or anabolic steroids. Remember, anabolic steroids aren't picked up in assays. Exogenous testosterone is, but if someone's recently been using it and then stopped, they will appear to have kind of a hypog picture. And so when this man walks into your clinic and says, oh, my testosterone is low, I need some treatment, you begin to wonder what the cause of that might be. In these individuals, if someone already started on testosterone misguidedly, then fertility is usually restored by simply stopping testosterone therapy and letting their own axis recover. So congenital hypog, so it's a failure to properly initiate puberty. It's low serum testosterone with low or inappropriately normal LH and FSH. Pituitary structure and functions otherwise normal, and you ruled out all other secondary causes. And it's a congenital genetic defect of GnRH secretion or action. Over 30 genes. We probably know the genetics of around 50% of cases, but there's more genes being discovered every year. And there's a high prevalence of cryptorchidism due to absent mini-puberty. There's probably around a 5 to 10% risk of transmitting the condition through spermatogenesis induction. So it's worth doing some genetic counseling to couples. And also non-reproductive phenotypes are common, found in around 60% of cases, most commonly anosmia, found in about 50% of cases, which defines Kalman syndrome. So this is what it looks to be a normal male. You have decent sized testes, decent testosterone level, good LH pulses every 90 minutes to 2 hours, and mature testes. And if you have congenital hypog, this is the severe form. This is what it looks like: tiny testes, 2 mil, no testosterone, apulse LH, and immature testes. Of course, around a third of congenital hypog men actually have a partial puberty picture. And in this case, a puberty begins but never completes. They either have low frequency LH pulses if you do the pulse tests, or there'll be low amplitude pulses, or there'll be only nocturnal, which is the early puberty pattern that just never progresses. How to use sperm in CHH? So, there's always a GnRH pump. It's beautiful endocrinology, just putting back the missing hormone and set it to pulse in every 2 hours. And it's really elegant. It's even been used to induce normal puberty, but it needs to be used continuously. it doesn't work in pituitary disease, and it's unavailable in many countries and unnecessarily expensive. So there we are. How can a decapeptide that was discovered nearly 50 years ago be made to cost $1,000 for 3 days supply? The wonders of modern finance. So in principle, we're generally using gonadotrophin therapy to induce spermatogenesis. So that's with FSH, which induces Sertolian germ cell proliferation. And when you combine it with micromolar testosterone, so paracrine testosterone, induces testicular growth and spermatogenesis. We don't use LH, the half-life is too short. We use HCG. They acts on the same receptor. Cheap forms and expensive forms of it. And that stimulates testosterone secretion by Leydig cells, which has endocrine, systemic effects at nanomolar levels, and paracrine affects the testes at micromolar per liter levels. And the paracrine action causes Sertolian germ cell differentiation and also inhibition of proliferation. So that makes you think, really, best to make sure you've got all your proliferation out of the way with FSH before you induce the differentiation signal, which is paracrine LH stimulated testosterone. So how likely is sperm reduction to succeed in hypog? So here's a case. So this is a man with hypog acquired post-puberty following treatment for acromegaly. His testes 12 mil, 2 children with his former wife, new partner, much younger, never been pregnant before, but regular cycles, premenstrual symptom, and now wanting fertility. And so you think, what has he got going for him, and what are the obstacles? Well, so firstly, men with adult onset hypochondroplasia testosterone may actually be fertile. In his case, not, he's asospermic. Second, you may also be able to restore or optimize fertility just with HCG alone. If he's previously been through puberty and mini-puberty, so his testes were fundamentally structurally intact with tubules. And so that's what and then of course, if you don't achieve fertility, you can then add in FSH or human menopausal gonadotrophin. So the fact he's had larger testes, previous pro-maternity, and a younger partner with regular cycles, these are all favorable things. So this is how we start. Time 0, he's off testosterone, hasn't yet started HCG, 12 mil testes, total testosterone is low. He's got some endogenous FSH on board, which is interesting. So he hasn't totally lost his gonadotrophins, but no sperm. We start him off on 2,500 units twice weekly, subcut. Testes grown a bit at 3 months. Testosterone 15. Estradiol beginning to overshoot there. Don't want it to go too high because that may precipitate gynecomastia. Anyhow, at 7 months, dose was still the same. Testosterone up above normal, free testosterone above normal, estradiol well above normal. Got some sperm, which is good, but we do need to dial down the HCG dose because otherwise he will be at risk of gynecomastia. And so at 11 months, we dialed on the dose, got 30 million sperm, but no bloods then. At 14 months, he's got over 50 million sperm, but actually testosterone is now low, and this is because his wife's pregnant and he's run out of HCG. So that's how relatively easy it is to induce sperm in a man with underlying decent fertility, just putting back HCG after he'd lost gonadotrophins due to acromegaly treatment. But HCG is not a panacea though. So let's look at men with congenital hypog, severe end, testes under 4 mils. And let's look at prolonged HCG therapy, for many, many years. And so 8 men, no history of cryptorchism, so these are already selected. So a lot of men with testes under 4 mil, congenital hypog will actually have bilateral cryptorchidism, but these are selected not to be cryptorchid. And at 1 year, most days are spermic, 1's got a few sperm. At 2 years, 5 remain asospermic, 3 got a few sperm. Up to 5 years, 3 asospermic, 4 got a few sperm, 1 got some. So really, even without cryptorchidism and prolonged treatment with HCG, if you got small testes under 4 mil, then really HCG monotherapy is largely futile. these men with congenital hypoc, they need to be started on FSH and HCG at the same time, whatever the guidance from the American Association of Clinical Endocrinologists say. In this group, severe congenital hypoc, HCG monotherapy is largely futile. It's a waste of time. The wife's getting older, her fertility is falling. These men need combined gonadotropin therapy right from the outset. And also in these men, it's actually quite hard to normalize the serum testosterone until you add HCG. And so during that period, the libido, sexual function often suffers. So this a surrogate for fertility is your final testicular volume in CHH men after combined HCG and FSH therapy. And we see that the larger your testes, the bigger your final testicular volume. So the smaller your testes are at the outset, the less they're going to grow during combined therapy. Again, your lower your inhibin B level at baseline, the less your testes are going to grow during therapy. And if you're cryptorchid at the beginning, the less they're going to grow during therapy. And if we look at sperm outcomes, this is after 3 years of therapy, up to 3 years of therapy, who gets any sperm at all. So if you're one of the lucky third of men with CHH and kind of partial puberty, testes greater than 4 mils, 80% will get sperm. But that means 20% still won't get any sperm at all. If you're the majority of CHH men who present with absent puberty, half will get sperm, any sperm at all. And if you had a history of cryptorchidism, then very few men will get any sperm at all, even after prolonged therapy. And what kind of sperm counts are being achieved? Well, again, if you are the severer end with testes less than 4 mil, the kind of median sperm count achieved at your peak is about 10 million, which is not stunning. Whereas if you're the minority of patients, the third with them, partial puberty presentation, larger testes, you can get up to around 30 million. These are not stunning sperm counts. So we're putting back all the hormones, and we're not quite getting the results that we would like to get. And so certainly having adult onset hypoc, having been through mini puberty and puberty already, is a positive predictor. Having testes bigger than 4 mil, indicating partial puberty, is also a good thing. Not being cryptorchid is good, so there's no thermal or surgical trauma, and potentially indicating a mild underlying neuroendocrine defect. Having a higher baseline inhibin B level is good, which basically tells you you've got more Sertoli cells, and not having a CAL1 mutation, or some posting X-linked Kalmans. And what about in treatment? What can you do within treatment to improve your outcome? Well, actually achieve a decent serum FSH level. Aim to get the FSH greater than 4 units per liter. Adjust your FSH dose accordingly. And obviously avoid HCG monotherapy if you're starting off with like small testes to begin with. So in this case, why do all the traditional sperm induction regimens begin with an HCG only phase? Why is that what's in the textbooks? Well, first of all, because they work for men with adult onset or acquired hypoc, and the assumption was they ought to work just as well for men with congenital hypoc, but as you can see, they don't really. Second, FSH is more expensive, whereas HCG is cheap, and the thought was, well, try out the cheap stuff first before we pull out the expensive stuff. And also, unfortunately, in licensing studies of FSH products, the regulator insisted on an HCG monotherapy phase prior to giving the investigational drug. And this is to exclude men who'd failed to normalize testosterone on HCG alone, which is a lot of them, and also men who'd achieved even a few sperm on HCG alone. And unfortunately, what the regulators required as part of their protocol kind of got translated into clinical practice, even though it has no underlying logic. So start HCG, titrate the dose until normal testosterone is achieved, which isn't always easy, and only use FSH in desperation towards the end. And so here are my reason to avoid HCG only regimes or HCG first regimes in FSH naive congenital hypoc men. It's very hard to normalize the serum testosterone with HCG monotherapy, but if you start them with FSH and HCG, it's effortless. We know that HCG monotherapy in these men is largely futile, even after prolonged therapy. And so given that these men will just about all need FSH anyway, and any initial HCG only phase is hard to execute, and it's frankly pointless. So give FSH to all men with congenital hypoc right from the outset. And the other concern is that the HCG-stimulated testosterone may induce maturation of immature germ and stellate cells before they've had a chance to proliferative. So you wonder, not only is it actually futile, but might it actually be doing some harm in the long term? There's also a suggestion coming from a study by Dwyer and JCM some years ago, suggesting that in men with like very severe hypoc with tiny testes, particularly those with bacterial organism, there may be a sense to actually give them an FSH only phase, a couple of months of FSH only to proliferate their germ cells and spagonia before you then introduce HCG. And during this phase, you can actually carry on with exogenous testosterone therapy. How you titrate an HCG dose? We're looking to achieve normal blood count, testosterone, and estradiol level. So I've got 3 more clinical cases here. So this is emergency admission. This is a CT scan, man with headaches. Here we see the enlarged expanded pituitary fossa. And here we see the MRI, large tumor compressing the chiasm, going into laterally into the cavernous sinuses. And practice greater than 100,000. So from the endocrinologist point of view, we're going to treat this with cabergoline. Patient's hypopituitary, but the tumor will shrink. The hypopituitary may then recover. In the interim, we'll treat with hydrocortisone, testosterone, and maybe thyroxine, maybe with testosterone as well. However, we may miss the other perspective in that his wife is 38 years old. She wants fertility. We haven't got months or years. She's running out of runway. And therefore, really, even though we expect things to improve with cabergoline, actually, he needs HCG and probably FSH treatment right now, just to get his sperm count up before his wife gets beyond the fertility age. So case 3, it's a 30-year-old man with Kalman syndrome, not cryptorchid. He was okay on testosterone gel, small testes, 3 mil, azoospermic, got married, young wife, regular menses, wanting fertility. His team started him on FSH, but kept him on testosterone gel. I'm not totally sure why. He's still azoospermic after 2 years, but the testes are now 6 mil, so they have grown a bit. And the couple were then referred for donor sperm. Luckily, that referral got intercepted and passed on to me. And of course, we know that this treatment was pointless. We know that FSH and exogenous testosterone can't induce sperm production. So we carried on with the FSH and started HCG, and we titrated the dose of HCG to achieve decent levels, but whilst avoiding gynecomastia risk. And so this is his weekly FSH dose. This is weekly HCG dose, testicular volume, total testosterone, FSH, inhibin B. And let's go. So at 1 month, he's been on 2,500 units twice weekly of HCG, and we got this quite big overshoot of hormone levels. Note those FSH levels at the bottom as well. At 3 months, we've knocked the HCG dose down a bit, and there's still some overshoot of hormone levels, but thank goodness he doesn't get gynecomastia. Inhibin B level coming up nicely, it's a total cell marker. At 7 months, we've knocked the FSH dose down even more. He's just on 2,500 a week. Hormone levels kind of approaching, still above normal, but approaching what normality. FSH level here still below target. And at 10 months, we've adjusted his FSH dose. We got the levels into target. We've got the right dose of HCG at last. Testes increasing in size all the time. Testosterone, free testosterone, estradiol, all normal range. Inhibin B nice and high. He ought to have sperm, but he doesn't. What's gone wrong? Well, what's went wrong is that I didn't examine him properly. So actually, he coincidentally had bilateral vas deferens agenesis, and so he needed TZ, testicular sperm extraction, and ICSI in order for his wife to fall pregnant. Case 4, presented with absent puberty and congenital hypoc, age 19. And this is where we take the older men and boys through puberty very simply with an injection of libido, 1 gram every 4 months. And at the end of the year, they're through puberty and they're very grateful. They get very frustrated by the kind of pediatric regimes being misapplied to older men and sustained on 50 milligrams monthly. It totally winds them up. But actually, he was still cryptorchid. He'd missed the pediatric net, and he's had an undescended right testis, and he was slated for orchidopexy. However, his urologist said to me, well, I can do this, but actually, tiny little 2 mil testis, it's quite hard to fiddle around, and also the somatic cord is short because it hasn't been exposed to paracrine testosterone. Can you make his testes bigger and his somatic cord longer, which will make surgery technically easy for me? I said, sure, no problem. So we started him on FSH, and we discontinued the libido. And after 3 months, we added HCG and fitting units twice a week, continued the FSH. And actually, at the end of 6 months, both testes were down in the scrotum. So this was medical orchidopexy. It didn't require surgical orchidopexy. Put the hormones back in again, and the testes will come down. And this looks like, in the sense that we replicated his missing mini puberty. Would have been sensible to carry on and bank his sperm, but he wasn't ready for that. So how do we improve sperm outcomes in congenital hypoc? I think the key thing is actually you being right at the beginning of life. You in boys with bilateral cryptorchidism, particularly those with micropenis, do a blood test. Do the blood test between 2 weeks and 4 months of age. LH, FSH, and testosterone, and those who got level 000, you've diagnosed absent mini puberty. Treat them with FSH and LH, these little boys. Bring their testes down medically. And they won't need surgical orchidopexy with about 90% probability. We know that from many studies now. So it's a question of getting the neonatologists on board and thinking properly. It's also important to signpost men with congenital hypoc to specialists whilst their partners are still young. Sometimes, unfortunately, I get referred patients whose wives are 38, 39, 40, and it's all a little bit late, really. Initiate treatment with congenital patients with FSH. HCG alone is pointless. Actively adjust your FSH dose to achieve target levels. Actively adjust your HCG dose to achieve target levels. Don't give up until at least 2 years have passed, but plan for early assisted reproductive techniques if the partner's older, and then consider doing sperm banking afterwards. And then in the offspring, test them for absent mini puberty. So many thanks for having me speak to you. Here is some background literature that you may find helpful. If you go onto my ResearchGate website, all these are free to download. So good night and salam alaikum. Bye-bye.
Thank you very much, Dr. Richard Quinton. And I think we have about 10 minutes left for our question and answer session. All our speakers will be joining us for the question and answer session. So if you have any, please type into the question and answer box. Dr. Richard Quinton is unable to join us live. So if you have any questions for him particularly, please mention your email address with your question and we will get back to you. So I'm gonna be asking Dr. Waqas to lead the question and answer session. Over to you, Dr. Waqas. I think your mic is mute, Dr. Waqas.
Thank you very much, Dr. Umar. So the first question is for Dr. Ali Imran. Dr. Ali, there was a question for you earlier. It was regarding checking the random cortisol when the patient is coming for hyponatremia. Is that adequate, or should we go for morning 9 a.m. cortisol?
Hi, Waqas. Thank you so much. Can you hear me all right?
Yeah.
Okay, thank you. First of all, again, thank you for inviting me. I'm sorry, I'm a bit sleep deprived. It's about 3 in the morning here. So, with respect to early morning cortisol versus random, really, it is ideal if you have time, and particularly in patients who are not non-acute hyponatremia, to check the morning cortisol. You can do a random one. The trouble is with random cortisol, you don't have a proper cutoff. I tend to use a cutoff of random of approximately 180 if I check it later in the day. And that is because typically for you to develop significant hyponatremia, your cortisol levels really have to be very, very low. If you have any decent amount of cortisol in your system, you would not develop hyponatremia. So random if you're using 180, but that's not really based on very good science, very soft data. But if preferably morning cortisol is always better.
Thank you, and special thanks to you for with us, especially early hour of the morning. So another question, which I'm going to ask to you, looking at your presentation, you mentioned about one study where they looked at correction of hyponatremia, severe hyponatremia in cancer patients, and they found that the survival have improved from days to months. In that study, did they have looked for the cause of hyponatremia or also regarding what sort of cancer that patient had?
I'm afraid the connection is lost. I don't know.
Oh, sorry. I can repeat the question. So in your presentation, you showed us a study where a patient with severe hyponatremia and cancer patients, when they were treated, their survival did improve from days to months. Did they also look in that study regarding the type of the cancer they have, or what was the etiology of the hyponatremia? Was it SIADH or other causes?
Yeah, so that I was not particularly convinced with those numbers, to be honest with you. This is why I said there was soft data. If you look at, there were only 57 patients, something like that in that study, a retrospective study. So the problem is that those data are somewhat ambiguous in to my mind. I am not sure if I can really tell from such a small study if we can draw any robust conclusions. To be honest with you, I think normalization of hyponatremia in cancer patients, I think the case has yet to be made if it will truly improve mortality. Morbidity, yes. Mortality, probably, we are unsure. And that's why there are strong limitations to that study.
Thank you.
I think, Dr. Waqas, I probably like to add maybe, which Dr. Imran said, that probably in some of the patients, when you try to correct hyponatremia in cancer patients, in some of the patients, you manage to correct it and they respond to the treatment. But equally, there are patients who are not responding to treatment where you probably can use the term refractory hyponatremia. And probably the mortality may be higher in that so-called refractory hyponatremia group. I don't know what Professor Imran thinks about it.
No, you are quite right. But that comes under sort of a hyponatremia being a prognostic indicator. So if you have bad hyponatremia, that is going to tell you that your prognosis is bad. The question is, if we treat it, do they get better? The answer is probably not.
Yeah, I agree.
Now from the audience, we have a question for Dr. Kiran. So is there any age limit for growth hormone therapy initiation in boys and girls, when it should be discontinued?
Assalamu alaikum. Can you guys hear me?
Walaikum salam. Walaikum salam. Yes, we can hear you.
So the main point to stop growth hormone is when your growth velocity slows down. So we typically use a cutoff of 2.5 centimeter per year. So if somebody is on growth hormone and the growth velocity is less than 2.5 centimeter per year, there is not enough growth left, so it should be stopped at that time. Regarding to the cutoff when it should be started, of course, the sooner the better, because data have shown that if there is the longer and the higher dose of growth hormone, the better the final adult height is. But again, you have to look at the bone age. Everybody uses different cutoffs, and it also changes over the years. But just to give an idea that if the bone age is around 12 years, so the 92% of the growth has been completed in girls and maybe a little less in boys. So if the 12 in girls and 14 in boys, that's the bone age. So then you can make an assessment, the risk versus benefit and the cost versus, how much medicine you're going to put the kid into the kid and how much growth you're going to get out. But the absolute point where you should not do growth hormone is when the epiphyses are closed.
And actually, the next question is similar to it. Is there any role of growth hormone therapy post-pubertal childhood? So I understand you mentioned if the epiphyses have already fused, then there is no role. But will it be a role if it's not fused in post-pubertal patients?
Yes. So if the bones are not fused yet, again, you have to see how much growth is left. There are different estimates that we can do to see how much growth has been completed and how much is left. And if the epiphyses are still open, it's always worth a shot. In post-pubertal, if the epiphyses are closed, then you treat it as adult growth hormone deficiency and treat for that reason, but not for growth promotion.
Kiran, this is Ali. Can I ask a question if you don't mind?
Sure, sure.
So what I find is something which I probably would you know better. In that particular age group you mentioned, post-pubertal, still there is some growth potential. Do you use sex steroids, a small amount of sex steroids, as an adjunct to growth hormone, or would you just give growth hormone, wait for them to squeeze another few centimeters out of their height, and then use sex steroids?
We use sex steroids sometimes in kids who actually have constitutional growth delays. So they are at the age of puberty or should be in puberty, but not at that stage. Sometimes when the bones are almost closed and there is, the height is not where it should be, we use aromatase inhibitors just to block the estrogen and keep the bones open for a longer period of time. But again, that's a therapy for more than 2 years to get the benefit. The aromatase inhibitors are not going to give you benefits in 3 months.
Thank you, Dr. Kiran. Sorry, yeah, I was just going to say that we have another session starting over here, so we're going to have to close this session. And I would like to thank all our speakers, Dr. Kiran, Dr. Ahmed Imran, Dr. Ali, and Dr. Richard Quinton, who spoke, and then especially a great thanks to people who joined us for the question and answer session, and Dr. Waqas for co-chairing with me. I know this discussion could have gone on a lot longer, and we could have all learned a lot, but in the interest of time, I'm going to have to say goodbye. Thank you, everyone, for joining us today.
Thank you. Thank you for having us.
Thank you.